So I'm going to start by talking about SLT and then direct SLT. I gave a similar talk a couple of years ago because we were starting to see more referrals for patients getting SLT, and then there's been some updates in the research and literature, and then in the past year there's been the FDA approval of the direct SLT machine, which we have a few of that I want to go through and talk with as well. So in terms, we'll talk about SLT, like I said, go back to the literature review, and then introduce DSLT. Last time I was here, I talked about the COAST trial as well, and we'll provide some updates with that, and then some case presentations. So SLT has been around in the US for about 25 years when it initially received its FDA approval. It was preceded in terms of laser trabeculoplasty by argon laser trabeculoplasty. If we think back to 25 years ago when it came out, we were kind of in the traditional glaucoma management paradigm where you pretty much started patients on drops and you kept adding drops until they were either progressing or couldn't tolerate drops anymore, and then you were forced with a surgical option, which usually was a trabeculectomy or a tube shunt. And so around that time, there was an uncertain role when SLT came out as to where this was going to have a role. And then about 10 years later, after the SLT got FDA approval, we had the entrance of MIGS with the eye stent. So overall, we have all these options, but it was kind of a difficult time to figure out where this laser was going to be used and how it was going to be effective, and then where in your practice you were going to use it for which patients. And then about 8 years ago, they came out with the first iteration of the LIGHT trial, which looked at the use of laser trabeculoplasty in patients with ocular hypertension and glaucoma. And this was based over in Europe. So one of the things that's interesting about this study, and we'll go through both the 3-year data and the 6-year data, is that not only did it look at how effective this was, most drug and surgical trials look at effectiveness, they also had a strong focus on quality of life. And with glaucoma, this is really important. I think it's something, decades ago at glaucoma management, it took a back seat just because there weren't a lot of options that offered improved quality of life. So as we know, glaucoma itself has adverse quality of life effects. The current mainstay of treatments was with eye drops. As we all know, with adherence, side effects, and cost, eye drops are not always sustainable. One interesting fact is that with the patients who are diagnosed with glaucoma, their average life expectancy is somewhere between 9 and 13 years from the time of diagnosis. And so the purpose of the LIGHT trial was to compare drops versus SLT as a first-line treatment in patients with open-angle glaucoma and ocular hypertension, looking at 3- and 6-year data. They looked at how effective it was clinically, cost-related, and then also their quality of life. So in terms of the methods, so they took patients who had newly diagnosed ocular hypertension or open-angle glaucoma, no other eye surgeries that they'd had other than just straight cataract surgery. They utilized real-world scenarios. So they had people who had IOP goals. It wasn't very as strict. And then they basically allowed the treatment to intensify based on their follow-up and the severity of the glaucoma. So in one group, they had SLT, where they just basically had a standard protocol, which we all follow. And then for the other group, they had drops, and they followed a very similar drop progression that we all use here, starting with a prostaglandin and then a beta blocker, followed by an alpha agonist or a carbonic anhydrase inhibitor. And then treatment escalation was just based on the progression of glaucoma or IOP that was deemed uncontrolled. And so in the SLT group, they were allowed to have one additional SLT, then they had to add a drop. And then in the drop group, of course, they added a drop as per the progression above. So in the 3-year data, they had about 720 patients. They found no difference initially in the health-related quality of life. In the SLT patients, so the patients that had no drops, they just had the laser. Within 3 years, 95% of their patients were at their target IOP, and 78% of them did not have drops. 76 of those patients required one additional SLT. This is compared to the drop group, which, as you can see, is relatively similarly effective. 93% of patients hit their target IOP at 3 years, about 60 to 65% just using one drop. So if we look at this, so the patients in the drop group, they did require more treatment escalation versus the SLT group, meaning they had to add more drops. 11 patients in the drop group ended up requiring a surgery such as the trabeculectomy to lower the IOP. That was 0 in the SLT group. The drop group had more treatment-related adverse events. So as we can imagine, these are side effects of the drops. Versus SLT, there were very few. And then in terms of cost, the cost analysis saw that in the SLT laser group, they had a lower annual cost on healthcare overall than compared to the drops. So their conclusion was that initial SLT for open-angle glaucoma or ocular hypertension is not inferior when compared to drops. They had lower rates of glaucoma progression, fewer additional surgeries, reduced cost of surgery and for surgery and glaucoma meds, and it required less adherence to a treatment protocol. So if we think back to our patients who are newly diagnosed with glaucoma, and we think on average they have somewhere about 10 to 15 years of life expectancy, if we can do something for a few years to keep them off of drops, it can be something that can drastically improve their quality of life. Then 3 years later, they came out with their 6-year data. So they changed the methods a little bit. So for this one, they had their SLT group. They were allowed to have an additional SLT treatment, so they could have a max of 3 SLTs. And then they allowed for this process called crossover. So they took patients that were in the drop group. They could choose to switch over to the SLT group in an effort to either decrease the drop burden, to escalate treatment, or to avoid or delay surgery. So in terms of groups, the results, once again, no difference in the healthcare related quality of life targets. In the SLT group, this is at 6 years. 94% of patients were at their target IOP. 70% were drop and surgery free at 6 years. In the drops group, we had 95% of patients were at their target, and 61% were using 1 to 2 meds compared to 20% in the SLT group. And then in terms of surgery, 2.4% of the SLT group and initially required trabeculectomies eventually, compared to about 6% in the drops group. So they had very similar conclusions. So overall, I think this was a big trial that came out in the last decade that I think has really changed how we utilize SLT, and it's been something we've been able to counsel our patients with, and it's always helpful to have hard data that we can use. And this has been really instrumental in trying to, get people as a first-line treatment for glaucoma who maybe are on one drop to offer a procedure that is very safe, it's very effective. We usually tell patients it's just as effective, if not more effective than drops alone, and can get them off of drops and help with follow-up. There was also some other studies that have been looking at follow-up, and it turns out that patients who have had some sort of a procedure in their life are more likely to follow up with their doctor rather than just being on medications. And so they looked at this with glaucoma, and they looked at studies where they had patients who were just on eye drops, which they just assume are just like medications, versus someone had an SLT or a cataract surgery. You're more likely to follow up with your provider for ongoing care if you had a bigger intervention such as a laser. So next I'm going to talk about the direct SLT. This is done through our direct SLT machine, which is the Voyager, which is through Alcon. So when you compare the SLT and the direct SLT, the SLT uses an indirect application of the laser. So you use a gonio prism with goniosol. They're seated at the slit lamp, which I'll show in a video here shortly. And then it's a 360-degree treatment typically. Most of us do 100 shots. Those shots are manually delivered. So with the laser, we can see the trabecular meshwork, and then we can apply the laser. And usually this procedure takes about 60 to 90 seconds to do each eye. With the direct SLT, as you can see in the diagram, the SLT laser is applied directly to the limbus and trabecular meshwork area. So because of that, it's contactless. It doesn't require a lens or goniosol. As you'll see in the video, the patient is typically standing at the machine. Once again, it provides 360-degree treatment with about 120 shots over the course of 3 seconds. So I'll go through this. This is, I think if I just click here. So this is just a standard SLT. I was going to speed it up, but I'll just switch to the next slide eventually just to kind of drive home, the things that are a little bit more burdensome. So for one, for every patient, they're brought in, they're the same pre-op process, but you're putting a lens on the eye with goniosol. Typically, this doesn't bother patients, but in some younger patients, especially younger men who tend to be a little bit more skittish, they don't enjoy having things touching their eyes, and so they don't do as well with this. But in general, the lens goes on, and then for about the next 60 to 90 seconds, you're applying this laser. About every 15 to 20 shots, you have to rotate the lens. And as you can see here, you have to change the laser settings throughout. A lot of times with patients, they have trouble getting positioned into the slit lamp. As we know, with the older chairs that we have and the machines, it's harder to get patients, especially elderly patients who have positioning problems, to get them effectively into the slit lamp, get their forehead kind of flush against the front. That way we get adequate visualization. So there are situations where this can be quite difficult. And then if you're not getting good visualization, sometimes they squeeze, the lens comes off, you have to reapply and start over. So I'll switch from this. And this is the direct SLT. And so I'll kind of just comment on it through here. So it's a much quicker process. So the patient is given the same drops. As you can see, she's standing at the table. Instead of having a lens, we just put a little eyelid speculum in that helps hold the eyelid open to get good visualization. And then from this side, this is done with a GoPro video. She puts her head in the machine, and then once you get it in focus, this laser will actually recognize the limbus. And so what they do is they focus in on the limbal area, and then when she hits the next button, you'll see a red ring. That just delineates where the program figures out where the limbus is, and then you just agree and say, yep, this is where the limbus is. You can adjust it as needed. And then once she hits go, you'll see it start to flicker, and it's about 3 seconds, so right here, and then the patient's done. And then you just take the speculum off, and all the post-op is pretty much the same. So it's a pretty quick, effective treatment as well. But as you can see, just from a patient perspective, it's a much quicker thing. They're not as blurry afterwards because of all the drops and the goniosol you're getting as well. So in terms of the DSLT data, that's kind of the big thing that we're still waiting on a lot of the more long-term data, but the initial studies that they've done and why it got its FDA approval is that it definitely does have an effect on IOP. It's been shown to lower the pressure, and it's been shown to be safe and effective. The one thing we're waiting on is just looking at head-to-head trials where you have people doing direct SLT versus SLT, and then looking at a comparison trial or a non-inferiority trial to see is it as effective as SLT? There are obviously advantages to this. So as you can see, patients not having to sit in a chair, kind of hunched over from a provider perspective, similar with you guys doing, your gonioscopy or applanation, having to get kind of crunched into the chair for 2 minutes. It can take a while and be burdensome. Tolerance, people tend to tolerate this a little bit better. Like I said, for some reason, if someone's gonna pass out in your clinic, it's a young man. And so being able to get a lens on the eye and can be really hard for people who are squeezing and just really adverse to that. And then also just the training and access. With this DSLT machine, it's a pretty quick training to do, and then obviously you can do more and it's less burdensome on your clinic. In terms of disadvantages, like I said, we're still waiting on the long-term data to be able to compare it to SLT. And then also the other thing is that it requires limbal recognition. So in patients who have kind of an ambiguous limbus, if you have a lot of arcus, or patients who are contact lens wearers who have a lot of corneal pannus, sometimes when you try and get it registered, it can't find the limbus, and then you can try different positioning techniques, but many times you have to forego and just do traditional SLT. Next thing I'm going to provide is the update on the COAST trial. So I talked about this a couple of years ago. So this is clarifying the optimal application for SLT therapy. So the purpose of this trial was with the movement of trying to get SLT as a first-line treatment for glaucoma. We're trying to move away from the paradigm of having traditional glaucoma treatment of just doing meds and then surgery. And so there was a thought and a hypothesis if there's a way, instead of just treating somebody with SLT and then have them go, and then once they start progressing, you could try and repeat it, or you could add drops, is if there was a way that you could use a lower dose SLT and they just come in every single year and you just repeat this low dose SLT, and then that's their standard treatment. And so what they did is they took two groups, one group that had traditional SLT with the normal energy, and then another group that had a lower dose SLT of 0.4 millijoules, and they followed them over time. In their initial trial, they found that the traditional SLT outperformed the initial low-dose SLT. And so what they ended up doing is stopping the trial for patients who got the low-dose SLT. And so now they're continuing the trial where they're having everybody get traditional SLT, and then they're comparing people just getting an annual low-dose SLT after that versus treating with the traditional SLT as needed if there are signs of progression, and those results are pending. So just here's some case examples that I have for patients who I think where SLT is an excellent option. So first we have a 50-year-old female who came in with suspicious cup to discs. Mom had glaucoma, so she has a direct relative with glaucoma. Pressure is borderline and drop naive, minimal cataract, and as you can see here that she's got some minimal thinning on her RNFL. So this would be a great opportunity if you make the diagnosis of mild open-angle glaucoma, where you can take a young person, keep them off of drops, and likely get a 15 to 20% reduction that would keep them off drops for quite a while. I always tell these patients too, they always ask about, well, how long is this going to last? You also think, well, you're probably within a decade or two of needing cataract surgery, which is another opportunity where once again you can tackle glaucoma without having to put people on drops as a first-line treatment. Another one, we have an 83-year-old male, has had cataract surgery at both eyes, new onset dementia, has known moderate POAG, Tmax is 26. He's currently on 3 medications, 1 combo medication with a definite moderate POAG appearance. I think this is an excellent opportunity to try and limit drops. Many times in these patients, it's either a caregiver or a parent who's at home who has to administer drops. And if you can come up with a way to say, hey, if we can just give 1 drop a day versus giving 3 different medications, this is a way to continue treating somebody while lowering their drop burden. This is a younger woman, 35, who I've been following in clinic. She has known ocular hypertension. She's had IOPs that have consistently ranged into that 27 to 30. And when you would normally look at her RNFL, you would say, hey, it looks pretty good. It's normal thickness. All of her progression looks okay, or her scans look okay. But as you can see, if you follow over time, that she does show progression in her RNFL over time. And so this would be technically an indication of mild glaucoma, even though that they have green on their little RNFL pie chart, because they're showing signs of progression with high IOP. So here's a way that you can take a young person, once again, keep them off drops and have a good potential to lower their pressure. And then finally, this is a patient who I've been following for the last year. He's a 24-year-old male. He has Conradi-Hunnerman syndrome. This is an X-linked dominant genetic disorder. It's usually fatal in men, but not in his case. He's had high IOPs in the 30s to mid-30s. The most difficult thing with his exam and his testing and ability to treat, one, he has very short stature. He's just under 4 feet, so we can't really do many appointments that are actually in a slit lamp without him kind of standing on the exam chair. He's very sensitive. They're very light sensitive in general with this condition, and he really struggles with drops. Like even putting him in himself, you can't even get close with an applanation tip or a gonio prism. And he had mild RNFL thinning. So I think this was a really good opportunity to do DSLT. Even though he didn't really tolerate the lid speculum, he did well with it enough. He was able to stand on a chair and then went up to the machine, and he's done really well. His pressures are in the high teens now off of medication. So that's another good example of finding ways to utilize the technology that's available to try and treat people. And then in terms of our panel discussion, so I had 3 questions that I wanted to lay out. First one was for Dr. Samuelson. So with the FDA approving SLT 25 years ago, just in your practice, obviously MEC is usually a pretty early adopter of technology. What SLT looked like 20 years ago, and then how you're utilizing it differently today.
Yeah, and ALT preceded SLT. So argon laser trabeculoplasty was the first laser trabeculoplasty, and then that was replaced with SLT, and now DSLT, as Dr. Leibow just demonstrated. And it's important to understand, and you made this point, that DSLT doesn't work better than SLT. No one would ever make that claim. And in fact, the FDA trial was to demonstrate that it was not inferior to SLT, not that it's better. It's absolutely better from a patient friendliness standpoint and doctor friendliness. It's better for both the patient and the doctor, but it works about the same. So argon laser trabeculoplasty actually caused tissue damage. It did improve outflow, but it actually caused architectural changes in the trabecular meshwork that probably makes MIG surgery less effective. So minimally invasive glaucoma surgery, where we're operating in Schlemm's canal and on the trabecular meshwork, probably is adversely affected by argon laser trabeculoplasty. So pretty much the entire glaucoma world has switched over to either SLT or now DSLT. The biggest change for me, Chase, is that we're doing it on a different patient population. My long-term bias is to say, well, I don't see the results in my hands to what they showed with the light trial. I just haven't historically gotten that good of outcome from laser trabeculoplasty. But the reality is I wasn't doing laser on this patient population. 30% of the patients in the light trial were ocular hypertensives. They just had enough glaucoma risk that they needed to be treated, either with some kind of pressure lowering therapy. They needed treatment. And in this study, they were randomized to drops or laser. And the laser, your slide understated it for sure. It said not inferior. Well, it was significantly superior in many facets. Secondary surgical interventions, less with the laser group. cataract surgery less with the laser group, suggesting is there some cataractogenic effect from our drops. So really, it's changed everything. The European Glaucoma Society was the first to come out and say that laser should be done first. Same follows in the UK, and then the American Glaucoma Society and the AAO, American Academy of Ophthalmology, recognized it as initial treatment. So it's changed everything, partly because the results are better when you use it early in the patient course.
Yeah, and then Kirsten, along those lines, so using it earlier in the course, we have the benefit of having wonderful OD colleagues like you all who we work with, and we're a referral center for glaucoma. So a lot of the patients that we see for glaucoma are not newly diagnosed, they're diagnosed by you. And so I guess what would be your advice for referring optometrists about, you get a patient who you're seeing who you think has, glaucoma or mild glaucoma, early signs, hadn't been diagnosed previously, and, having this plan to refer, but then deciding, when do you put them on something beforehand? Should you, or is there a problem if they're already on treatment ahead of time versus saying, I want you to get SLT, but do you need to do something in the interim?
Yeah, so I think SLT or DSLT is a great opportunity either as a first-line treatment or if the patient has already been started on an eye drop. And it's also great early in the glaucoma diagnosis management for co-management and sending the patient back to you as well. And then just seeing the patient back annually for routine testing and management and follow-up.
And then, yeah, I think similarly, I say, even if they come to me on a drop, that doesn't bother me. I'm, totally fine having someone show up on latanoprost, and then it's usually more of a counseling them to say, it's okay, we're gonna take this drop away and see what happens afterwards. I try and counsel them that, glaucoma typically is something that happens very slow over months to years. And so, I would say, doing this laser and just giving you 6 weeks without drops and see how your pressure does. Worst case scenario, you're back on your drop, but overall, I think it's helpful. So I think from a referral standard, I think you're able to send them to us without doing any treatment, and I think many of you are excellent about putting in your note, hey, discuss SLT. That just makes it so much more helpful for us to have that discussion with them as we're trying to lean away from saying this is like a surgical intervention, as more of this is just a gentle laser that is just as effective as eye drops. So I think that's extremely helpful. The one caveat obviously being if someone comes in with pretty high eye pressures, I think it's always, there's no downside to starting someone on drops before you send them or see them back for a pressure check. I think that's absolutely reasonable as well. And then Clara, the final question would be, I'd say most patients who I am counseling about SLT, eventually one of the questions that comes back is, well, you say this can last anywhere from 1 to 5 years. Then what, can it be repeated? How do you know when to repeat it? What are your kind of tips on that?
I tell everybody, my SLT patients, my MIGS patients, that unfortunately there's no cure for glaucoma, so we still will monitor you for glaucoma at the normal interval as if you were on medications. And it is very hard to predict how long the efficacy of the SLT will be, so we follow them with regular pressure checks. And if they can make it beyond 1 year post the initial SLT treatment, it is something that I would consider repeating in the future. If they failed within that first year, I tend to recommend not repeating SLT treatment at that time.
And I think there's some controversy on that, right? I mean, some people say that if you have failed SLT, because I think typically we say about 80% of patients have a 15 to 20% response to SLT, that if you fail it the first time, does anyone else try it again before saying, let's go to drops?
I didn't in the past, but I do quite frequently repeat it now. And Gus Gazard, who's the first author on the light trial paper, he believes that if you don't respond, it's not something biophysical with you, it's probably inadequate dose. And so he would just apply more laser energy. Now, at some point, you give up and we move on. And Dr. Chu's point that it's really important to emphasize to patients, there's nothing that we're going to do that's going to cure your glaucoma. The most important thing is to show up for your follow-up exams and make sure that whatever treatment we've used is still adequate.
Yeah, and I also think along those lines, one thing that I kind of counsel patients on, and this is sometimes hard for them to grasp, is once we decide on some sort of a treatment, whether it's drops or whether it's SLT, I kind of put them in a different category as to what's going to cause us to do more treatment. So at that point, even if they initially have pressures that drop and then they go back up to where they were, beforehand, I don't count that as a treatment failure. I personally look at that and say, until I see worsening of the testing, I'm not going to advance treatment, because a lot of patients come in and their pressures are, high teens, low 20s, or even higher. And it's possible that just getting them down to low 20s is all they need. And so it's not like I see a pressure and say, well, now I'm going to treat on that. For me, I typically won't treat until I see some progression of the RNFL or a new visual field defect, at which point, then you're kind of saying, okay, this makes sense to treat. But I tend to shy away from just treating pressures.
I think that's a really good point, Chase. So a lot of times the pressure's, marginal, but they've had an intervention like that. Quite often, studies have shown that the diurnal variability is less, and quite often when people are progressing, it's not because they're progressing at the pressure that we're measuring when they're in our office. They probably are having higher pressures at times when we're unaware. And so SLT and some of the MIGS procedures have been shown to flatten that diurnal variability so that perhaps their pressure may not look that different, but their disease might be better controlled.
All right, thanks. I'm going to move on to Dr. Ju.
Good afternoon. I'm going to be talking to you about the interaction of glaucoma and dry eye. I have no financial disclosures. I picked this topic because not that dry eye is not my favorite disease to treat, but it is a super common clinical scenario that I encounter in my practice, and these are questions that I think about in almost every glaucoma patient that I face. So I thought this would be super high yield. I'm going to describe how glaucoma and its treatments can impact pathophysiology of underlying dry eye disease, how dry eye disease can impact quality of life and glaucoma care, and outline glaucoma treatments that can minimize the impact on dry eye disease. We know that glaucoma is a progressive optic neuropathy characterized by a characteristic loss in retinal ganglion cells, and this causes a stereotypical visual field loss associated with genetics, age, as well as elevated intraocular pressure. And elevated intraocular pressure, as we know, is the main modifiable risk factor. Dry eye disease is a multifactorial ocular surface disease characterized by a loss in the homeostasis of the tear film. The meibomian glands produce the most superficial lipid layer that limits the evaporation of the tear film. The lacrimal gland and conjunctival epithelium produce the aqueous layer, and this is the layer with the largest composition of the tear film. It constitutes of water, nutrients, electrolytes, and immunoglobulins. And then conjunctival goblet cells contribute the deeper mucus layer. There can be an aqueous deficiency, such as seen in Sjogren's eye disease, evaporative dry eye disease, where the lipid layer is deficient, such as in meibomian gland disease, or there can be a combination presentation. So there are multiple key factors with dry eye disease, including tear film instability, increased tear osmolarity, ocular surface damage, neurosensory abnormalities, as well as inflammation. And each of these components can potentiate each other. And importantly, the most common preservative that we use, benzalkonium chloride, can potentiate multiple of these steps of the cycle, including contributing to tear film instability, contributing to goblet cell loss, damaging the ocular surface, and contributing to inflammation. The interaction between dry eye and glaucoma is quite common. Among glaucoma patients, depending on the study cited, dry eye prevalence is anywhere from 15 to 50%. And the converse is true. Among dry eye patients, the glaucoma prevalence is anywhere from 11 to 21%. Long-term glaucoma medication use can induce discomfort, tear film instability, meibomian gland dysfunction, subconjunctival fibrosis and conjunctival inflammation, and epithelial damage. When looking at glaucoma patients, up to 70 to 80% of patients can have asymptomatic dry eye. There may not be any signs and symptoms that you can see on the clinical exam, but on a molecular level, there may be signs of conjunctival changes that you cannot see. Mild dry eye is also super common with glaucoma patients. Up to 40 to 50% of them manifest dry eye signs, including corneal staining or symptoms of dry eye. And then severe dry eye changes, such as the cicatricial changes seen on the top right-hand photo, is fairly uncommon, but it again can be seen with some glaucoma patients. We do know that surface disease is correlated to the glaucoma severity as well as how long the patient has had glaucoma. So patients that have had glaucoma longer than 6 years have a higher ocular surface disease index than those who have had glaucoma less than 6 years. And this is linked to poor drug compliance to long-term regimens, and we know that glaucoma is a lifelong disease, and it can also be related to higher failure rates of filtration surgeries. So this was a study out of the VA, and they surveyed 74 patients, and they asked them about their compliance to the glaucoma regimen, dry eye symptoms, as well as concurrent systemic diseases. And 80% of the veterans reported a compliance to the regimen greater than 75% of the time. 39% of these patients reported dry eye symptoms, and there was a difference in compliance. For those that reported dry eye symptoms, 63% of the time they had reported good compliance, whereas those who did not report dry eye symptoms, there was improved compliance of 89%, and this was statistically significant. There were similar associations with the presence of anxiety and post-traumatic stress disorder. Factors that were not associated with poor drug compliance included demographics, depression, and interestingly enough, the complexity of the glaucoma regimen. The number of drops and the frequency of the drops did not seem to be associated with poor drug compliance. So treating dry eye might help improve medication compliance. In this basic science study, they looked at inducing a dry eye model by applying topical benzalkonium chloride. The other half of the patients served as controls, and I'm sorry, my slides got rearranged here, but basically each of the groups underwent a trabeculectomy, and then they had eye exams for the first postoperative month, and then the eyes were subsequently sacrificed. And in the top row of photos, that is the control group where there was no dry eye disease that was induced, and there was a shrinking in the real estate of the blood, and there was some fibrosis, but there was still a small functional bleb at the end of 2 weeks. Whereas with the dry eye model, there was fibrosis that was induced, and by the end of 2 weeks, there was no bleb to speak of. When they sacrificed the eyes, the control groups had normal conjunctival goblet cells as well as normal epithelium of the conjunctiva, whereas in the dry eye disease group, there was a goblet cell dropout as well as squamous epithelial metaplasia. So why use preservatives in eye drops? Well, they have antimicrobial action, and that helps to increase the shelf life. The most common preservative that's used is benzalkonium chloride, and that's found in about 70% of eye drops. This works by destabilizing the cell membrane of bacteria and fungi, leading to the lysis of these pathogens. And it also degrades tight junctions of corneal epithelium, and this helps to increase the penetration. But there are many bad side effects of BAK, including tear film disruption, damage to the corneal epithelium, the conjunctiva, and then deeper structures in the trabecular meshwork as well as in the meibomian glands. It can recruit inflammatory interleukins, fibroblast growth factor, platelet-derived growth factor, and matrix metalloproteinase 9, and induce subconjunctival fibrosis. So limiting BAK exposure theoretically would improve ocular surface disease symptoms. In the table on the right, and highlighted in the box in red, those are the concentrations of BAK that are typically available in commercially available products. But even at the lowest dose, at 0.004%, there is a decrease in the tear breakup time. And then it can go all the way up into altering the epithelium, the endothelium, and also reducing corneal wound healing. In concentrations that are not typically seen in commercially available drops, There can be major toxic keratitis, as well as destruction of the cornea and the conjunctiva in a very short period of time, in less than 1 week. When thinking about alternatives to BAK, there are a couple that are available on the market now. One is Purite, found in alpha-Gen P, Savzia, found in Travitan Z, and then potassium sorbate, that's found in Zelpros. These alternative preservatives tend to be gentler on the surface of the eye. The preservative itself may break down quicker upon ocular contact, or they might allow for a smaller concentration of the active ingredient, again, being gentler on the eye. There are also preservative-free formulations that we can think about, and there are short-term data to suggest that it improves tolerance and compliance to regimens without compromising on IOP lowering efficacy. However, less long-term data is available. So looking at 3 studies from around the world when looking at preservative-free medications, this study out of Finland followed 158 patients, and they had existing ocular signs and symptoms of dry eye while on latanoprost, and then they were switched to a preservative-free tafluprost and followed for 3 months. They found that the pressures were maintained with latanoprost, and then the switch to the tafluprost, the pressures remained between 16 and 17 millimeters of mercury. But when they surveyed the patients, they found that the reported ocular symptoms did decrease in a statistically significant manner. So the patients, while they were on the latanoprost, reported a higher rate of tearing, burning, irritation, dry eye symptoms, and that proportion went down statistically significantly, the bars in the green, once they made the switch to the tafluprost. And then when these researchers examined the objective signs on the eye, they also found a difference in the conjunctival and corneal staining, an improvement in the abnormal Schirmer testing, and blepharitis. This study out of Korea showed enrolled 107 patients in a prospective trial, and they were placed on a 12-week trial of either tafluprost, dorzolamide timolol, preservative-free, or preserved latanoprost. They followed patients for patient satisfaction, their ocular surface disease index score, as well as pressure results and safety. And they found that there were no safety concerns between the 3 groups, and that the pressure lowering was comparable between the 3 groups, but that there was an improvement in the ocular surface disease index score in patients with using tafluprost or preservative-free dorzolamide timolol as compared to latanoprost. And a similar finding was found with a higher patient satisfaction score with the tafluprost group compared to latanoprost. And then in this 3rd study out of Spain, they enrolled 92 patients in a multi-center study, and they had to have an existing poor response to monotherapy of either a beta blocker or prostaglandin, or they had poor tolerance to that. And then they were switched to a combination preservative-free tafluprost plus timolol. They found that there was a meaningful reduction in the pressures from 22 millimeters of mercury to about 17 millimeters of mercury at month 6, and that there was a reduced proportion of hyperemia, dry eye, irritation, and foreign body sensation and eye pain. The bottom graph on the right shows the proportion of conjunctival hyperemia. The darker bars on the left show the proportion of either no hyperemia or mild hyperemia, and then the bars on the right show moderate to severe hyperemia, the proportion of patients. And you can notice at baseline, there's a larger proportion of patients that report moderate to severe hyperemia, but by month 6, that bottom bar there, that proportion shrinks down, the moderate to severe disease. So we know that preservatives are not great for the surface long term, but what are the barriers to adopting preservative-free therapies? Number 1 would be cost, both the absolute cost to society as well as the copays that an individual patient faces can be higher compared to their generic preserved alternatives. Number 2, availability may also be an issue. They might not be available as much on the global market. And they also might not also be available to patients to access at their local pharmacy. The pharmacies may be having trouble sourcing it. Number three, we're also part of the problem, I would say. There are some issues with prescriber awareness and practices. Preserved eye drops have been on the market for much longer. It's easier to default to the generic preserved option there. And a mindset change may need to occur. We might want to be proactive about protecting the ocular surface as opposed to thinking about preservative-free options for only patients that are currently experiencing dry eye. And then finally, there are a lack of preservative-free formulations that are available in different active ingredient combinations, as well as the fact that most of these are single-dose vials. So that does produce extra waste, and it also can present dexterity issues for those with arthritis, as the vials are much smaller. So applying this to practice, the first step is to identify ocular surface disease and know that the symptoms and signs may not correlate. The first thing is to ask the patient as to how they're doing. Document the patient's symptoms both at baseline and at subsequent visits. There are a multitude of symptoms that can be a presentation of dry eye disease, but oftentimes they're also asymptomatic, so it's not something to just ask them about, and you need to follow up with them on the clinical exam. There are a couple of validated questionnaires that can be used to help facilitate this surveys process, including the Ocular Surface Disease Index as well as Dry Eye Questionnaire. OSD tends to be a little bit more affected or confounded by the severity of the glaucoma, but the Dry Eye Questionnaire is an easy 5-part survey that is a little bit more objective to elicit their complaints. And then, of course, following up with a good clinical exam of the cornea, conjunctiva, tear film, and eyelids are important. Using staining techniques can be helpful in identifying dry spots. Fluorescein tends to highlight corneal defects, lissamine green tends to highlight conjunctival defects, and if they have either 5 corneal spots, 9 conjunctival spots, or if there's staining greater than 2 millimeters from the inferior lid margin, this is a positive test. Tear breakup time can help identify evaporative dry eye disease. It is abnormal if the breakup of the tear film happens in less than 10 seconds. Schirmer's test can help identify aqueous deficiencies if there's less than 10 millimeters of tear that is soaking on the tear paper and at 5 minutes. And then other things can help to evaluate tear quality, including osmolarity testing, as well as inflammatory biomarker assays, such as for matrix metalloproteinase 9. The morphology of meibomian glands can be assessed with infrared meibography. Corneal sensation can also be assessed by esthesiometry, which it could be as simple as using a cotton-tipped applicator to the cornea, or you can use a retractable nylon monofilament to assess corneal sensation. And then corneal nerves can be visualized with confocal microscopy. And then it usually does not need to come to this, but impression cytology and conjunctival biopsy can be helpful in identifying inflammatory mediators. It can help identify how the conjunctival goblet cells are looking, how the epithelium morphology is doing, and then if there's any recruitment of additional cells like macrophages, fibroblasts, and lymphocytes. So we've defined the problem. How are we gonna go ahead and treat the problem? So it's a 5-step process. The first step is to think about symptomatic management, and that could be as simple as adding lubrication eye drops, serum tears, or inducing extra tear production with varenicline. If there's any concurrent meibomian gland disease, that needs to be managed, whether that's with warm compresses and heated masks. If there's Demodex present, that needs to be treated as well. And then doxycycline can be used to help induce an anti-inflammatory effect, and hypochlorous acid spray can also help to reduce the disease burden on the eyelids. And then there are in-office procedures that can be considered. There is thermal pulsation, that is a device to heat and massage eyelid margins to liquefy and express gland secretions. There's intense pulse light. This is a light energy that is applied to the eye, and it causes coagulation and ablation of superficial blood vessels. and this helps to down-regulate cytokines and inflammatory mediators. And then finally, radiofrequency can also be applied, which is high-frequency electrical currents that are applied to heat up the eyelid. You can increase the contact time of tears to the ocular surface by adding punctal plugs or adding contact lenses to the surface of the eye. Perfluorohexyl octane forms a monolayer on the ocular surface, and that helps to inhibit the evaporation of the tear film. And then nerve growth factor analog, Cenergermin, can be used to help treat neurotrophic components of keratitis. Number two, we need to think about reducing the preservative burden. So we can choose preservative-free alternatives, choose alternative preservatives to BAK, and then if needed, using eye drops and combining them so that we limit the amount of BAK administration that is needed throughout the day. Another component to think about is adding anti-inflammatory drugs to the dry eye treatment. We know that cyclosporin helps to increase the goblet cell density and increase tear production. Lifitegrast helps to down-regulate T cell recruitment and activation. And then a low-dose steroid can be used in a selective manner to help calm down the ocular surface. In the glaucoma world, I always think about limiting the possibility of a steroid response, but in small, short doses, it might be something to help control the dry eye initially. And then thinking about other glaucoma management options besides eye drops include SLT, as Dr. Libo had discussed. It helps to reduce the drop burden. It reduces the likelihood of needing further surgical interventions, and a higher proportion of these patients do achieve their target goal as opposed to patients that need to use medications. There are many minimally invasive glaucoma surgery options that can be used to help limit the amount of medications that are needed. For example, in the COMPARE trial, when they looked at the Hydrus group, they found that 1.6 drops were reduced in the medication burden, and in the iStent group, about 1 drop reduction was found. Minimally invasive glaucoma surgeries can also help save and preserve ocular surface tissue by limiting the exposure to BAK. And it also might help prevent the need for a bigger surgery with filtration surgery. Filtration surgery can be very effective to help lower the pressure in the eye, but oftentimes it requires an antifibrotic for its successful use, and that might affect long-term structures, for example, at limbal stem cells, and it might affect ocular surface permanently. And if there are any blood-forming procedures, a low-lying bleb is a wonderful outcome, but sometimes it can cause bleb dysesthesia if there's a high architecture bleb that might distort the tear breakup time, as well as symptoms of ocular surface disease. And then finally, I'd like to talk about long-term drug delivery platforms. There are 2 that are commercially available at this point. One is the bimatoprost intracameral implant. It is a 10 microgram biodegradable implant. Its effective drug dosing is for 4 to 6 months, and it is 4,400 times more effective than topical bimatoprost. Currently, it's approved for one-time usage due to concerns for corneal endothelial damage with repeated injections. And then the travoprost intracameral implant is a 75 microgram slow-eluting implant in a titanium reservoir, and this is anchored to the trabecular meshwork. Its effective drug dosing is for about 12 months, and it has the intention to release effective drug for up to 3 years. And this is 25,000 times more concentrated than topical travoprost. So by using these specific drug delivery platforms, they can pack a big punch and have a higher effective dosing inside the eye with a lot less drug delivered to the eye, all the while saving the ocular surface. So glaucoma and dry eye disease are common diagnoses, and they can compound the severity of each disease and affect quality of life. It's important to both assess and ask about glaucoma and dry eye disease together. They are common concurrent diagnoses. Ask about the symptoms. Even if they're asymptomatic, look out for signs of dry eye disease on the exam. Think about proactively limiting the use of preservatives where possible and practical. Treat dry eye by lubricating, using anti-inflammatories, and treating concurrent meibomian gland disease. And then besides medications, think about other options, including laser and surgical options and long-acting delivery systems. So I have two cases that I'd like to present to the panel here as to pick your thoughts as to what you would do. So this is a 65-year-old woman who has had a long-standing history of moderate stage normal tension glaucoma. She says her vision's okay, but she's noted a chronic red eye. Pressures are okay, 12 to 14 millimeters of mercury from a maximum pressure of 19, and she's on Combigan and Travoprost. She has a positive dry eye questionnaire score of 10 out of 22, and this is her clinical exam with noted conjunctival hyperemia and inflammation. And her visual fields are stable after a phaco eye stent that was performed about 5 years ago. So I'd like to pick the panel's thoughts about what they would do to potentially modify the drop regimen, if they would consider SLT or some sort of long-term drug delivery option, and if something would change if they're thinking about surgery. So I'm going to go back to the prompt here. So with regards to the drop modification, Dr. Snyder, is there something that you would potentially suggest with regards to the Combigan and Travoprost?
Yeah, I think I would consider more of a long-term, like Durista implant or intracameral medication in order to get the patient off of at least the topical Travoprost, and maybe with the sustained delivery, maybe also be able to modify the, just do like Timolol in the morning. I also might consider doing SLT as well to augment the result.
Dr. Libo, is there something about the eye exam that would make you consider maybe not just doing medical management? What would make you tip your way to potentially thinking about some sort of surgical management? What kind of algorithm would you go through?
So when I look at this looks a lot like brimonidine toxicity. Like if I had to guess what's causing the issue, it's very rarely Travoprost or any sort of prostaglandin that tends to not have as big of an issue. So I guess what would tip the scale, once again, I mean, if her pressures are in the low teens, Tmax is 19, I mean, you could approach this a couple ways. One, you could just try stopping Combigan and see how their pressure does and just, test it, like just give it some time. As Dr. Snyder said, you could just say, let's just do Timolol in the morning, Travoprost at night. I'd be more inclined to do something more procedural, like she had mentioned, and you could try just doing SLT and stopping the Combigan, keep them on Travoprost and just see how they do. I think something, and I think like the Durista works well, but I would say that once again, your Durista is kind of your Travoprost, and so I don't know, you're kind of just replacing that. I don't know if it's more effective than Travoprost itself. I think iDose would be a great option here, but I always kind of have that with a grain of salt, like it's a trip to an OR, so you have to look at them systemically. She's also young, she's 65, so what are we doing long-term what are we thinking long-term about what they have, down the pipeline to try and lower their pressures. I'd probably start with SLT and stop the Combigan and just see how they do. And once again, like I said before, I'd probably follow until they show signs that they're progressing.
And then Dr. Samuelson, I'd like to ask you, this is a patient with normal pressure glaucoma. Let's say we go through all of these options that Dr. Snyder and Dr. Libo had discussed, but let's say patient's still very symptomatic and has a similar history where the fields are still stable. What surgical options would you be considering in trying to achieve a low goal pressure?
Yeah, it's a perfect lead into my talk, which is follow yours. Because I do think we have a lot of different options, and much of the determinant on what you do is how tolerant are they of adjunct therapy. I agree with Chase and Kirsten that brimonidine is likely the culprit here, and they may do well just on travoprost alone, for example, or QAM, timolol, travoprost QPM. They may be much happier. So I initially try to get off the brimonidine. I frequently couple SLT and drug delivery like Durista, for example. I think that has a chance to get you off all three if you combine them. But if you do have to go to a surgical procedure, the fact that their visual field is stable, it's reassuring and concerning at the same time, because those visual field defects are deep and close to fixation and likely symptomatic because they're the inferior field, which tend to be more symptomatic. So you have to really consider that their glaucoma is severe and threatening, especially to a 65-year-old, but she's stable. So I would consider like a GAT procedure perhaps on an individual like this. I'd be a little reluctant to give her a bleb, given that she's been stable. So we're really just trying to improve her quality of life here. So I would just med reduction choices and not putting her too much in harm's way in the surgical risk side.
So what I did was I performed an SLT, and then I got rid of the brimonidine component and switched to preservative-free timolol, and went from travoprost to preservative-free tafloprost, and she had good improvement in her symptoms there. We did have a discussion about doing Durista or doing iDose. We've had some insurance coverage issues, and the question about the repeatability of a Durista injection. Personally, for me, I've always wanted to see what the long-term corneal effects are. So I personally actually have not jumped on the Durista bandwagon quite yet. I'm waiting to see if there can be FDA approval for repeated injections. And then a second case here. So this is a 73-year-old man. He has moderate stage glaucoma in the right eye, severe stage glaucoma on the left eye. This is a photo of his left eye. There's a lot of irritation and tearing. His best corrected vision on that left eye is 20/80. Pressures in that left eye is 28, poorly controlled with topical travoprost in both eyes, Cosopt on the left and brimonidine on the left, and there are follicles, mucoid discharge, and corneal pannus with a nuclear sclerotic cataract. And then the fields here are showing aggressive progression of the visual fields over 2 years. So my questions for the panel, and I'll just leave it open here, is in what scenario would you do medical management in this case, and then what kind of surgical options would you be offering for this patient? I'll go back to this.
I mean, I consider them I pretty much would say that they're on max topical therapy and not tolerating it. As you can see, I think the one benefit for this person is that they still have a cataract. Then the question is it a 20/80 cataract or not? It's probably more glaucoma. So I think with the left eye, I think depending on, their overall health, and then I usually give them two options in this situation. I would say we could do cataract surgery with a goniotomy, like an OMNI, and try and remove, the brimonidine and the Cosopt and just keep them on travoprost. I counsel them that this is a quicker procedure, it's less invasive. It does have risks, obviously, with bleeding, but the recovery tends to be a little bit faster. But I also counsel them that, there's a good subset of patients who won't respond enough to a goniotomy and end up needing an incisional surgery, which for me would be a tube shunt in this patient, given their conjunctiva. And so I kind of offer them, two options. One being do the cataract and do a goniotomy, knowing we might be going back to the OR in the next 6 months to do a tube shunt if they don't respond enough, or just go straight to a cataract tube shunt if they want an effective procedure that would get them off of hopefully all of their drops.
I think you brought it up, Chase. If you are thinking about a tube shunt, I agree. I probably wouldn't really change the medications. I personally actually did a phaco-trab in this situation, but I don't know if anybody modifies their drop regimen going into something that requires conjunctival disturbance. Does anybody change the drop regimen or put people on something extra?
Kirsten?
Yes, I think in a patient with significant injection like this, I would stop at least the bromonidine preoperatively and start the patient on prednisolone for a week or two to try to get the injection down prior to a trab.
I would say exactly the same thing. Pound them hard with steroids preoperatively and get them off what you think is the most likely surface toxic med, probably bromonidine, but followed secondly by dorzolamide. But in my experience, if you do a trab on this patient, your success isn't nearly as good as if you quiet the eye down first. And then it's hard to tell. I presume it's a wide open angle, or you would have mentioned it, but if this was a compromised angle, it looks a little bit crowded, but it's a one-dimensional picture. You can't really tell. If it was a narrow angle, getting the cataract out, maybe it was something conservative, as Chase was offering, might be enough. But from the start, I thought this is a phaco trab or tube, probably based on the severity of the disease. And this is what we're trying to avoid these days. I mean, we generally should be able to, these really sick, toxic eyes, we should be able to prevent patients from presenting like this.
Welcome. I'm Tom Samuelson, been at this practice for a while. In fact, we're shorthanded today because we would normally have Dr. Riedel here. He's unable to be here today. Chris Larson's gone, and Mark Hansen. So we've got half of our glaucoma team basically. But we're also missing Dr. Lindstrom. I just want to spend a minute or two because he usually gives kind of a big perspective, and we miss that. He's not practicing anymore, but he has huge impact in our field. These are my disclosures. A lot of them relevant to what we're going to talk about, but I'll try to mention it. So I joined Dr. Lindstrom 34 years ago, and we've gone through a lot of changes over that time, as you can see. And the reason I'm bringing it up is just last month, I got to present Dr. Lindstrom with the ASCRS Hall of Fame Award. So the American Society of Cataract and Refractive Surgery enters one, sometimes two people into the Hall of Fame each year. And it's not just the US, it's all over the world. It's anyone who's an ophthalmologist anywhere in the world is a candidate to enter. This year there was one entry and it was Dr. Lindstrom, which was pretty special. Yeah. And there's no one else from the state of Minnesota that's ever been in the Hall of Fame in this capacity, and I'm not even sure about the upper Midwest. So it's pretty special. So we're going to talk a bit on surgical glaucoma, not so much how to do it, because that doesn't interest you as much as, how do we decide what procedure to do for any given patient? Because we've got a multitude of options now. And when you think glaucoma, you think optic nerve, you think Schlemm's canal, trabecular meshwork. Those are the real important features that you're considering. But I would submit the status of the native lens is among the most important things that we use to decide what's our next step. It just came up in Dr. Chu's case, he's going to have cataract surgery. How do we manage that? So the native lens, what's its role in the pathogenesis of glaucoma? I think I've presented at this meeting in the past that I think there is a correlation between the thickening, enlarging mass behind the iris that's pushing the lens iris diaphragm forward, encroaching on the canal a bit. So there is a role, I think, of the native lens in the pathogenesis of glaucoma. How does it influence the glaucoma when you remove the lens? What happens to the IOP? How do we best manage cataract and glaucoma together? And also maybe get the panel's thoughts on, what are the lens implant options for our patients with glaucoma? I do a lot of light adjustable lenses. I do presbyopic correcting lenses, toric lenses. We do all these things in our glaucoma patients, but we have to be a bit more selective because we know diffractive optics can reduce contrast sensitivity and glaucoma visual field loss can reduce contrast sensitivity. So we have to be pretty careful. It's a nuanced decision-making process, but I personally believe our glaucoma patients want to have favorable refractive outcomes too. And so we correct astigmatism and we do all the same things they're used to. So back when I started practice, we basically had 3 surgical options: trabeculectomy, tube shunts, and cyclophotocoagulation. And now you can see this is not even a complete list, but the number of options that we have to offer our patients are enormous now. And how do we make some of those decisions? So first, when do we decide to surgically intervene for glaucoma? Well, generally when there's unacceptable risk of progression despite laser trabeculoplasty and medication. So and you can include intracameral drug delivery in that. And more recently, as we've just heard, as an alternative to medical therapy, we're doing some of our less invasive surgical procedures as an option for patients that maybe don't do well with drops. But by far the most common time to intervene surgically for glaucoma is when someone's going to the operating room already because they've got a surgical cataract. And I'm constantly telling our patients that cataract surgery is really something to look forward to for many of our glaucoma patients. Frankly, it's true in general. It's such a good operation. But for patients with glaucoma, there's so many ways you win with cataract surgery. It lowers eye pressure 80% of the time. It's a chance to improve vision. It's a chance to improve refraction. It's a chance to improve the configuration of their anterior chamber angle. So lots of good things happen. And we almost always combine cataract surgery with a minimally invasive surgical procedure, and sometimes a more aggressive surgical procedure, as Dr. Chu just mentioned, for some of our patients that have more advanced disease. But by far, the phacoemulsification, high quality phacoemulsification, is the foundation for our MIGS procedures. It's just critical that we do a good job removing the cataract, and that's the bulk. I tell patients that cataract surgery in the control arm of the MIGS trials, and we were involved in a bunch of them. So cataract surgery alone was compared to cataract surgery plus some of these minimally invasive things. In cataract surgery, the control arm lowered pressure by 5.3 millimeters of mercury in the 5 MIGS prospective randomized trials. The MIGS portion offered a couple additional points. So, cataract surgery is a touchdown. The iStent or the Hydrus is maybe the 2-point conversion. So as I mentioned, 2-year washed out pressure reduction in the control arm, the cataract surgery alone in the MIGS trials, and these are all prospective randomized clinical trials under the purview of the FDA approval process. So really high quality studies. Cataract surgery alone helped. So if we're gaining already by taking the cataract out, we want to make sure that we're not going to subject the patient to a lot more risk by doing other more aggressive things if we don't have to. And I said, as an aside here, interventional pharmaceuticals, which is what we're calling like Durista. So for those that aren't familiar, we used that term several times previously. There is intracameral bimatoprost, which is Durista, that we can put in at the slit lamp. And I tell patients that, on average, patients get somewhere between 6 and 9 months of pressure control. A third of patients got more than a year. So there is a chance they can get longer. And as Dr. Chu alluded to, it's on label by the FDA as a one-time dose. There is hope that we could repeat it in the future, but on label is different than being illegal. I mean, it's not illegal to do a second dose. It just might not get covered, and you have to be careful about prior authorizations and such. But I've got several patients that have done 3 and 4 over the course of 4 or 5 years. So you can repeat it. I personally think the endothelium risk is low. What got the FDA's attention in the trial, we put 3 in. We put 3 in a 6-month period, and they tend to stack on one another. So that's why there was this pause on doing multiple dosing. They approved for 1 year, and then anything beyond that's off label. So it's important that I disclose that. It's off label if you do it repeatedly, but it's certainly, we do all kinds of things. Mitomycin's off label for use with PRK, but we do that all the time as well. So for mild to moderate glaucoma, which is what most patients with glaucoma have, before you've done anything as an adjunct to the cataract surgery, you're already really winning. So it's important not to put them in harm's way. So in the setting of moderately good canal physiology, so as I mentioned, most people with glaucoma worldwide have mild to moderate disease. We tend to see a lot of severe disease because we're at the narrow end of a big funnel. But for most of our patients, we want to pick a procedure that's least likely to disrupt their current physiology. Least likely to create a fibrotic healing response, or more importantly, least likely to cause a catastrophic complication, because glaucoma surgery can cause catastrophic complications. Hypotony can cause suprachoroidal hemorrhage, or a bleb can cause bleb-related endophthalmitis. You can get too low of a pressure with some procedures, and they get very blurry vision because they get contraction of their axial length, and now the retina has some folds in it. So glaucoma management is all about risk mitigation. And I showed this slide at various meetings. Apologies if I've used it here before, but if you haven't seen Free Solo, it's an amazing movie. This guy climbs El Capitan with no equipment. It's unbelievable. Risk you subject yourself to is one thing, but risk you subject a patient to is a completely different thing. And so there's going to be risk no matter what procedure we pick. If we undertreat the glaucoma by picking something too innocuous or too modest in efficacy, then there's more disease risk because maybe we're not adequately lowering their pressure. But if we pick something really aggressive, now there's more surgical risk. So we're constantly balancing the disease risk. And as we know, the disease can be completely asymptomatic. If you have a early nasal step or a subtle nerve fiber bundle layer defect, we're going to treat that, but we don't want to subject patients to more risk than their disease gives them. And of course, glaucoma can be severe and blinding, as some of the cases we just saw, so we do have to make sure we're treating it adequately. On the surgical side, there's the risk of being disappointed if your pressure doesn't become lower with SLT. I'm constantly telling patients, not everyone responds. Maybe 80% of people respond, but the risk of this procedure is the risk of being disappointed if you're one of those. It's not visual loss from SLT. At least I haven't seen it. And then, as I mentioned, there's catastrophic risk. So I'm just going to take you through. Most of you are probably pretty familiar with these, but I know it's a pretty diverse group in terms of experience. So maybe not everyone has seen iStent. So this is iStent. Goes in, at least I put it in after patient. You can see that's a presbyopic IOL there. So this patient had mild enough glaucoma, I felt I could do that. But iStent is a tiny little device that we put in Schlemm's canal. We generally put 2 or 3 of these in. There's something called iStent Infinite where we put 3 in, but the diameter of that is 0.3 millimeters. And if you laid Schlemm's canal out on a table, just spread it out longitudinally, it's 36 millimeters. So the 2 of them combined are about 0.6 millimeters. So we're leaving the overwhelming majority, like 98% of the canal, untouched with this procedure. So pretty hard to cause a lot of harm unless you're fumbling around and have a complication. And frankly, you're operating in a very small environment. Schlemm's canal in vertical height is about 1/5 of a millimeter. So it's really fine detail. So if the patient, has abrupt movement or something, bad things can happen. But in general, that's pretty rare. So the one on the right is the Hydrus. And so this is, if iStent is 0.3 millimeters long, Hydrus is 8 millimeters long. So we're covering a much greater portion of the canal. So almost a full quadrant here. If 36 divided by 4, so it'll be 9 millimeters. We're covering 8 millimeters here. So about 1 quadrant. So it goes in this little catheter here. You pierce trabecular meshwork to gain access to Schlemm's canal. And then this stent goes in the canal to help keep it tented open. And there's an inlet that helps aqueous enter into the canal. So Hydrus, definitely a bigger procedure than iStent. And probably Hydrus has the best data among the MIGS procedures. Not saying it's the best, I'm just saying they have the best data because they have 5-year data showing less visual field loss. So they have longer studies. The FDA kind of required them because you are doing more with that. Now, those 2 are somewhat minimalist compared to GAT. So my 3rd most common operation in the angle is gonioscopic assisted transluminal trabeculotomy. It sounds, you know, like a mouthful, and it is, but it's pretty easy to decipher. You do it under gonioscopic visualization. You're doing a trabeculotomy, you're opening the trabecular meshwork, and you can do a quadrant, you can do 180 degrees, or you can open up all 360 degrees. So to me, it's the most comprehensive thing we do in Schlemm's canal. And I'll just show you an example. This video is a little bit blurry, but a couple of it demonstrates what I'm trying to show. So we just pierce the canal there. This catheter is just deploying viscoelastic, so we're dilating the canal. We're causing some viscoelastic to go up into the collector channels. Remember, the collector channels, Schlemm's canal drains into the collector channels, which drains into the episcleral veins. So you get this reflux of blood. Every patient I do a GAT procedure on, I tell them expect to have a hyphema for, I don't say hyphema, they don't know what that is. I tell them expect to have blood in your eye for a good week or so after this procedure. It's just gonna happen. Now look at, here's what I wanted to show you. This portion right here is a wide open Schlemm's canal. So we're opening Schlemm's canal completely. You can do gonioscopy and look in and see the back wall of Schlemm's canal, and I do show you that picture in just a second. But that white that you see is the back wall, so trabecular meshwork is gone. But these patients get a hyphema. These patients have blurry vision for a week. These patients occasionally have to be irrigated out. Not very often, maybe, my experience, 1 in 20. How often do you irrigate out a GAT because of a retained hyphema? Have you had to in the last year? Yeah, pretty uncommon. So what I was showing here is you can see this, the slide on the left shows the blue catheter in Schlemm's canal, and then I've stripped the TM, and that white you see right here, if that's showing up, yeah, that's the back wall of Schlemm's canal. So it's basically a direct access to the canal now. All right, so now it's a watershed moment when we start to give up on Schlemm's canal. Some patients require a whole new drainage system. So this is a Zen. So we've gone from iStent to Hydrus to GAT to now this is Zen. We've given up on the physiological outflow. We're going to create a whole new outflow channel. And so this is a little stent that communicates from the anterior chamber into the subconjunctival space. So this is a bleb-forming procedure. This does take hypotony, puts hypotony on the table as a risk factor because there is no floor to the pressure. The pressure could go as low as because there's very little resistance in the subconjunctival space. So the physiology of the engineering of the stent is such that it's designed not to allow hypotony, but it absolutely can. And so now we're taking more risk for this patient because supposedly their disease warrants us to take more risk, but we're doing more. And then beyond that, I still think trabeculectomy is my most effective way to get very low pressure. So for people really in trouble, we still have to do a fair number of trabeculectomies. We do far fewer than we used to, In fact, Dr. Snyder and what's probably the most common thing that fellows in training talk about these days is, are you getting enough trabeculectomy, right? Nationwide, just because we're doing so fewer trabeculectomies because the things that we have proximal are working well. If everything we were showing prior to this was failing, we'd be doing as many trabeculectomies as we always have, but we're not. So we're sparing patients trabeculectomies or tube shunts, and you can see on the right is just putting a tube shunt in. So, and I think all of our practices are filled with people that would otherwise have lost all vision if not for these more aggressive procedures. So I want to consider a hypothetical exercise here. So and my philosophy might be different than everyone on the panel here. But how many in the room have taken a visual field just so they can empathize with their patients, just to know what they're doing, right? So almost all of us, right? We've tried a visual field just to see what our patients go through. Well, let's consider this. Let's just say, even whether you need it or not, everyone in this room is going to consent to a glaucoma procedure, right? We've all done visual fields. Let's just say we're all going to pick a glaucoma procedure to have done on us, right? Whether we have glaucoma or not. So how many would sign up for a trab or a tube? Didn't think so. How many would sign up for a Zen? Don't see many hands. GAT, excuse me, GAT, you know, where we strip the inner wall of the canal. Oh, got to take her over here. Call me later. How about just a partial goniotomy? Because one thing I didn't show is there's something called a KDB, if anyone's heard of that, Cahook dual blade, where you just go in with a blade and you basically take out the nasal trabecular meshwork. The nasal outflow is considered the prime turf because that's where the majority of the collectors are, infranasal. So goniotomy goes in and just like a KDB or a Scion, you can go in and just remove the trabecular meshwork over that section. Anyone sign up for that? Couple? How about a hydrus? And the purpose of this exercise is we already acknowledged that some patients with glaucoma don't even know they have it, right? They've got a nasal step that's completely asymptomatic. They're fine. They're like, leave me alone. Just yeah, monitor my glaucoma and make sure I don't go blind, but don't do anything too radical on me, right? Okay, so how about iStent inject? That's what everybody picks. And it makes sense because, as I mentioned, let me just go on to this next. As I mentioned, 2 pi r is to figure out the length of the circumference of a circle. 36 millimeters, we're leaving 99%, 98% of the canal untouched. And so for someone with basically asymptomatic disease, maybe they're on 1 drop and you want to get them off that and you're doing phaco, sure, let's just pop in a couple iStents. On the other hand, sometimes you hit a home run with just the phaco alone, add an iStent. Now they're maybe 7, 8 points lower on less medicine. So I think it's a nice option, and as opposed to, I don't go in and strip out the TM of the really prized portion of the canal very often for people with mild disease. It just, to me, I don't know how that's going to heal, really. You might get a fibrotic response over time, maybe get more of a healing response. They're not that broken, so I don't want to do too much to disrupt that. So now, this just shows that continuum, and again, this is in my hands, and I'm just going to stop for just a second and ask my panelists. Kirsten, you starting practice in Sacramento in what, about a month or 6 weeks? So Kirsten's going to Sacramento, California to start her glaucoma practice. What's your philosophy going to be? The nice thing about our fellowship is you get to work with 6 glaucoma specialists and see how they manage different things. Have you found a MIGS procedure that you migrate to more than others?
I think that I have adopted a similar mindset to you, and I think probably incorporating a lot of these different MIGs in sort of a stepwise approach based on severity of glaucoma, but also adding intracameral sustained release medications too in there.
Yeah, that's a really good point, and I had a slide that alluded to that. The drug delivery things are relatively new. We're starting to get iDose. So Durista we put in at the slit lamp, and I've got a whole bunch of patients that I've done both SLT and Durista on within a few week period. And I say, okay, which was harder for you? If we had to do it again someday, which would you find easier? And they almost always say Durista. We don't tell them we're sticking a needle in your eye. We say we're taking this tiny little slow release piece of medication and we're putting it in I show them an eye model or show them the inferior angle. We're dropping it right down in here. Oh, okay, so they don't mind that. But if we told them exactly how we did it, they probably would object. But we do, I don't withhold anything from them. I just, we speak in non-medical terms. You don't tell a child they're going to get a shot. You're going to give them some medicine that's going to help prevent them from getting sick. So Clara, then Chase, what are your thoughts on mild to moderate? Do you have some go-tos? And I'm not saying up here that this is right. This is just what I do. We're all a little bit different on how we manage things. Clara, any thoughts on mild to moderate glaucoma, how you manage it?
Yeah, so I think about, one, I think we do need good visualization for all of these procedures. So I think about whether or not the patient, I think, is coachable and that the view during surgery will be reasonable to achieve placement. iStent inject is fairly straightforward procedure. If it is more moderate disease, it is my preference to do the Hydrus because it has better long-term visual field outcomes. But I sometimes think twice about patients for Hydrus if I think it's, for example, a long eye, if they're highly myopic and the canal may be a little bit more elastic, it might be more troublesome to put in a Hydrus with proper placement even now after doing it for several years. Other things that I think about is what do I want the goal pressure to be and what are the patient's expectations in terms of the number of drops that they're going to be on. If I am trying to reduce the number of medications that they're on and they need a really low goal pressure, you might consider combining different modalities to achieve a goal pressure there. I tend to reserve GAT. My GAT of choice is the Omni device that you had shown previously with the blue catheter. I tend to reserve that more for moderate to severe disease, but in those folks where I think they are at high risk for having a post-operative bleed, I might default to a Hydrus in that situation.
Good. That's spot on with what I think as well. Chase, do you limit your glaucoma patients on IOL choice?
I will if they have once they have a field defect, like a substantial field defect, I no longer offer multifocal. That's pretty much it. I mean, if someone has a severe field defect, I probably, I mention light adjustable lenses, but I do mention that most of their visual field loss is from glaucoma. But I think even people with severe glaucoma and severe visual field defects can benefit from astigmatism correction. So doing a toric IOL or LRI, just because you have a lot of field loss from glaucoma doesn't mean you deserve to be wearing glasses your whole life. So, but I also do think about the other eye. If one eye is severe and they have severe field loss, I do mention that, I kind of put them into a glasses precaution category where I say, it's in your best interest to be protecting your good eye. And so you can want spectacle independence if you're at home watching TV, but I don't want to get the mindset of when you're outside doing your day-to-day life that you should have something covering your eye.
I think your point about astigmatism correction in particular is well taken. I always think about whether or not my surgical intervention for glaucoma is going to change their astigmatism. So I always like to counsel patients that the astigmatism correction may not be totally predictable, and if they're accepting of that and we can reduce some of their astigmatism, I do think it's worthwhile doing. But for example, a trabeculectomy or a tube shunt, it might be very hard to get exactly on target for astigmatism correction.
Dr. Snyder, the patient on the lower left there, do I have to stop their Notarsadil because they've got that verticillata?
No, usually it's not visually significant.
Agree. You can get an epitheliopathy from Notarsadil, but this patient just clearly has verticillata. So I jumped ahead because we're going to do some questions, but I wanted to show this case that similar to Dr. Chu's patient. So, and someone in the audience might recognize this guy because he was referred in. He looked like that. And so he was on three eye drop therapy, referred in because he was no longer tolerating them, and I'd say that's an understatement. And he looked like that for relatively mild glaucoma, although his field was not the most reliable. And so we've already made this point, I think, so I'm just going to skip ahead rather than ask the question. He had no prior laser, and he was controlled on 3 meds. What I did was sequential, what we just talked about. I said, we're going to do SLT, and then when you come back in 2 to 3 weeks after that, we're going to pop a Durista in and look at the transformation in him on no drop therapy. So the point is that we've got lots of tools now and just touch the surface on how we make decisions on which we pick to use in any given patient. And it's pretty nuanced, but it's a lot more fun than it used to be because we just have great options now. So Anna, do we have questions? And
Yep, we should. I'm sure they've been coming in, so you guys will see them as they populate on those confidence monitors there. Guests can scan the QR codes on the tables, and our virtual guests can type in any questions into the Zoom chat. While we're waiting for a few questions, or are there some there already, Dr. Samuelson?
yeah, there's a whole bunch.
Oh, yeah, perfect, then go for
Chase,
it.
Chase, SLT and low tension glaucoma?
I think historically it's been thought to maybe not be as effective, but I tend to counsel my patients if they're already on a drop, is there a cost to doing SLT in a low tension glaucoma patient? Once again, I struggle with normal tension and low tension glaucoma as in terms of what their pressure really needs to be. A lot of people say they need to have low, high single digits or low teens. So I think it's totally reasonable to offer SLT, try and remove a drop and just see what happens with their pressures. I find that a lot of patients who have low tension or normal tension glaucoma can probably tolerate a little bit more pressure than what they thought initially. So I see it's a low risk procedure and worth a try.
Yeah, I guess I would say I just look at SLT as one more pressure lowering option. It's just like we would never not use a prostaglandin in low tension glaucoma. It might not be enough, but we would try it. So you just have to decide, does the velocity of the patient in front of you, is their velocity of their disease such that I can try a relatively, a modestly effective thing, or do I have to get more aggressive much more rapidly and do something much more definitive? So really, we talk about disease severity, but to me, disease velocity, number one, and likelihood of progression, if they've been stable for a long time, like the patient Dr. Chu showed, then we can try some of these more minimalistic maneuvers, but we all see patients that get worse almost right before our eyes. They're really aggressive disease, and we have to hit them hard with something far more efficacious. Claire, anything to add to that or some of these other questions that you see?
One question that was directed to me was how common is doing MIGS and stents without a cataract surgery or perhaps after cataract surgery? And I think that scenario is becoming more and more common. We're having more options that are available now. Dr. Samuelson alluded to the iStent Infinite, which is having 3 stents available on the canal, on the trocar, and that can be done as a standalone procedure, either in a pseudophakic eye or in patients that are currently phakic and don't need cataract surgery. Another option that we could consider is the Omni procedure or GAT. That's something that I commonly will do in patients where I think there is pathophysiology to the trabecular meshwork, such as in pigment dispersion syndrome or in uncontrolled pseudoexfoliation. There was another question, and I don't know if I misstated my statement. It says, why does dry eye disease increase the incidence of open-angle glaucoma? And that was not my intention to make that statement, if that was the impression I gave. It's just that dry eye disease and concurrent open-angle glaucoma, it just happens very commonly in both populations. And having dry eye disease can make a glaucoma harder to manage there. What pressure reduction would you expect to see in cataract surgery alone? Well, if you believe the published studies, they saw anywhere from, I think it was very high, anywhere from 8 to 10 millimeters of mercury. I found that kind of hard to believe.
I quote the GAT or the MIGS trials, and that was 5.3. But it's important as you look at that study or any other study, there's going to be some regression to the mean, because a lot of these studies require a number to enroll. So let's say someone's pressure's 22, 21, 19, 23, 21, 25. Oh, 25, we should do something. Oh, look, you're 25, your pressure's 25, you're a candidate for this study because you're required to have a pressure above X. But that patient, that wasn't their typical pressure, but that was their pressure that day that maybe the study came to mind. Now, our whole research departments up there, so they know that it's more involved in that. Usually we have to bring them back for qualifying visits and such, but it's hard to get patients that fit all the criteria for a study, and pressure number is one of them. Anytime there's a pressure number, you're going to get some regression to the mean, because that number may not be their true baseline, but it's the best we have. So, and it's also nuanced. Is the angle narrow? Is it wide open? What's your starting pressure? The higher the starting pressure, typically, the more any one treatment's going to lower percentage-wise, or absolute number-wise as well. So if the pressure is 25, you're more likely to get a pressure reduction from cataract surgery if that pressure is 15. The more dysfunctional the system, the easier it is to make it better sometimes. So if the growing cataract is impinging on the TM because the lens iris diaphragm is pushed forward, kind of the opposite of what pilocarpine does, if that's one of the mechanisms of raising pressure, number one, their pressure is going to go up, but number two, when you release that, it's going to drop their pressure down, as opposed to someone whose system's working just fine. You take their cataract out and it's not going to really change much. So, Anna, you watching the clock?
I am, yep, we are about at time right there, so I might have you guys stop. Any of the extra questions that we didn't get to address during the presentations, I think we've done this in past years. We'll send them out via email. We'll ping the physicians and have them type up a response, so we still get some answers to your questions. So thank you so much, glaucoma team. Don't